So, good morning, everyone, and welcome to the seventh session of the European Climate and Resilient Health Systems course. This session is focused on incorporating sustainability into health technology assessment. My name is Chiara Cadeddu, and you probably remember me from the first session where I was presenting a case study. Today, my role is different because I'm the moderator of this session together with Eric. Eric, please introduce yourself.
Okay, thank you very much, Chiara. Good morning, good afternoon, and good evening, everyone. Happy that so many of you are participating again in this seventh session of our joint ASFES GCC HE course and this European version. My name is Eric Toomey. I am the ASFER Fellow on Climate and Health, and together with Chiara, I will be moderating this session. We will start briefly in, again, outlining the logistics of this course. Most of you probably have read this already, so I will make it very brief. So the course objectives is essentially those 5 points. It's articulate and communicate to key partners and the public the unique challenges of health systems, including primary and secondary healthcare, face in a changing climate. It's also to apply methodology and frameworks for assessing vulnerability and adaptation for health systems in any context, apply approaches for measuring and monitoring the environmental sustainability of health systems and health co-benefits of transitioning to green health systems. Then apply a health equity lens into efforts to address health system decarbonization and climate resilience. And last but not least, develop an initial plan to increase the resilience of the health system vis-à-vis the estimated climate impact on the population and to engage with key partners to achieve meaningful adaptation. The course schedule is this. We are today at the session 7, March 18, incorporating sustainability into health technology assessment. And these are the learning objectives of today's session. First, to analyze the characteristics, merits, and limitations of methods and frameworks currently under development to allow integrating environmental considerations into health technology assessments. Second, discuss the ethical dilemmas associated with taking into account environmental considerations in decisions about health technologies. And third, explain how financial tools can be used to encourage progress towards sustainable and resilient health systems. Briefly, the logistics. As you know, these are 90-minute sessions. They include expert lectures and case study presentations. The sessions will culminate with the question and answer section moderated by Chiara and me. And you can start with the first lecture to enter your questions to the presenters. If possible, address the presenters directly with the name. And the session's video recordings, the slide decks, and other resources will be made available on the course website where you registered. Around the attendance, your attendance is automatically recorded during the live Zoom sessions, but your individual attendance is only counted if you join using your own personal Zoom link. Your attendance is not counted if you join with a colleague's link, and YouTube views will not count towards attendance either. You will receive a certificate of participation if you attend 70% or more of the live sessions and pass the final exam with a score of at least 70% at the end of the course. And a certificate will be awarded called Climate and Health from ASFER and GCCHE. The certificate of participation is only available to people who use the same email for registration and all Zoom sessions and the exam. The final exam must be completed using the same email address used the attendant and the Zoom sessions. The exam link will be sent on the final day of class via email and WhatsApp and will close on that Sunday. The format will include roughly 25 multiple choice and true or false questions. And participants should be prepared to take the exam in one sitting. And with this, I give back to you, Chiara, to present our today's speakers.
Thank you, Eric. Besides being a member of the working group on climate and health in ASPER, I'm the team chair of planetary health at the Erasmus School of Health Policy and Management. And so today it's a very pleasure to introduce as first presenter a colleague of mine at ESHPM, who is Frederick Thielen. Frederick is a distinguished researcher and educator in the field of health technology assessment and an assistant professor here at ESHPM at Erasmus University in Rotterdam, the Netherlands, and a senior scientific researcher at the Trimbos Institute in Utrecht, the Netherlands. Frederick's research activities are extensive and varied, particularly in HTA and the cost effectiveness of novel healthcare technologies. And Frederick also plays a leading role in education as the International Program Director of the European Master in Health Economics and Management. So, Frederick, the stage is yours for the first lecture.
Thank you very much, Chiara. Thank you very much for the introduction. I will share my slides now. All right, I hope everybody can see my slides. Hello everyone, and thank you very much for the invitation to present today. Today I will give you a brief introduction on how sustainability could be integrated into health technology assessment, or HTA in short, as we often refer to it. As you already heard, I'm Frederick Thielen, Assistant Professor in Health Technology Assessment, HTA, at the Erasmus School of Health Policy and Management, and I'm also a Senior Researcher at the Trimbos Institute, which is the Dutch Institute for Mental Health and Addiction. It is my very honor to be speaking to you, and already now I want to thank you for your time and your interest in this topic. So let's start. Because traditionally, HTA has more focused on costs and clinical effectiveness, but since environmental concerns grow, of course, and you heard all about this in this course already, we cannot ignore the impact of healthcare on planetary health. And over the next couple of slides, I will discuss key concepts, some methodologies and challenges related to this important topic. And I will start with some HTA basics first. To understand why integrating sustainability in HTA matters, we need to acknowledge a fundamental reality. Resources are limited. Financial constraints mean that every euro spent on one thing cannot be spent on another and are not available for another aspect. So, for example, a health technology that we reimburse at higher costs, these costs are forgone and we cannot spend the same amount for something else. And this reality forces difficult decisions. How do we allocate funds effectively while also ensuring the best possible health outcomes for all? These trade-offs are the foundations of HTA, and they guide us to make informed and evidence-based decisions. Every public sector, not only healthcare, of course, faces some constraints. So, for example, if we look at the European Union, then we can see that in 2022, the average healthcare budget across all European Union member states, EU member states, was 10.4% of the gross domestic product. And if we compare this, for example, to the education budget of the EU member states in the same year, this was around 4.7% of the GDP. And no matter the budget or the sector, so be it healthcare or education, we also need to be aware that these constraints are not only of financial nature, but they can also be related to workforce, resources, and other aspects, also climate, of course. The challenge is always to introduce new health technologies without worsening existing constraints. New technologies bring, of course, progress, but they also add financial pressure, and this can be substantial. If we allocate funds to new interventions, to new health technologies, then that money is no longer available for existing treatments. And so often already existing treatments need to be substituted and they need to go. Often new technologies are more expensive than the ones that they replace, and this makes cost effectiveness a crucial consideration. Alternatively, we could, of course, also look into cutting budgets elsewhere to pay for new technologies, for example, in healthcare. But if we do so, the problem will only shift from one sector to another, and we will not solve issues at all. So the core goal of healthcare policy is to ensure affordable and equitable access to effective treatments. This is done through a triangle of sustainability, for example, financial sustainability with a rational use of medicines, but also good quality. We want person-centered, safe, and evidence-based medicine, and it should be also equitable. So there should be no systemic disparities between patients. Everybody should receive what they need. But traditionally, the sustainability aspect, as I mentioned before, has referred to financial sustainability only. And now we increasingly consider also workforce and environmental sustainability in our decision making. So we also need to go through some definitions here, unfortunately. One of the definition of health technology assessments. So HTA is defined as a multidisciplinary process, meaning that we have different specialities working together, for example, medicine, statistics, economics, but also ethics. And this multidisciplinary process evaluates health interventions based on their clinical, economic, and societal impact. So it's not only economic, but also includes clinical and societal aspects. What these societal aspects are, I will discuss in a couple of slides later. So HTA acts really as a bridge between research and policy making, and this can ensure that healthcare resources, like for example financial resources, but also others, are used efficiently and effectively. So by this means, HTA tries to be transparent and accountable as a process as such. HTA can be defined in many different ways, but one is to define it with 9 core domains or 9 core pillars. 4 of these domains or pillars can be evaluated at a global level. For example, if we take the European Union at a EU level. Data on the current use of the technology, but also the technical aspects of the technology, and health technology being here anything from vaccines, medicines, to really medical devices or entire healthcare programs, but also their safety and their clinical effectiveness. They often come from randomized control trials, RCTs, phase 3 preferably, which are considered the gold standard for assessing the effectiveness, but also the safety of medical interventions. So this can be done on a European level because usually all these clinical trials are also multi-center, so they already happen in different countries at the same time. But since each country manages and finances their healthcare system like they wish and on their own way, a global assessment of the bottom 5 pillars is usually done on a country-specific level. So, for example, the costs of the treatment, of delivering the treatment, and all other economic aspects, together with ethical, organizational, patient and societal, but also legal aspects, they are really country-specific, and they are really focused on different countries or like a specific country, and therefore need to be done on a member state level for the European Union, for example. And in addition, the European Union has no mandate to decide for its member states how healthcare funds are allocated. So this is really something they need to do by themselves or in a couple of countries together. When we zoom in on the eco domain, which is the first on the bottom on the left side, so one of these core domains of HTA. So if we zooming in on the economics domain of HTA assessment, we can distinguish between several aspects that are usually all included in it. First, and maybe most prominently, the cost effectiveness analysis, which compares costs and outcomes. For this one, we are often using quality adjusted life years, so not only life years, which are short for QALYs, or disability adjusted life years, the DALYs. The analysis of cost effectiveness can help to determine whether a treatment provides value for money. And I will show the main outcome ICER, the incremental cost effectiveness ratio, on the next slide. Next, on the right, we have the budget impact analyses, which evaluate the financial burden of a technology on the healthcare system. And these analyses, they can help policymakers to decide whether an intervention is affordable given the available budget of a specific country. Often, cost-effectiveness analysis include broader economic factors, and these can, for example, include productivity losses, which occur when patients or their caregivers miss work due to the illness or treating the disease. Then also other societal costs, which include unpaid caregiving or other family burdens, and equity and affordability considerations are included as well. You can think here of, for example, out-of-pocket expenses of patients that are needing to pay extra for some treatments or some co-treatments out of their own expenses, which are not covered by the health insurance. And another crucial aspect is sustainability and systemic effects. Some interventions lead to cost savings by preventing hospitalization and reducing long-term expenses, so these effects should also be considered as well. Last but not least, we have decision rules and thresholds, which play an essential role in HTA. And this is because countries establish willingness to pay thresholds to really define what is considered cost effective. So at what level of threshold something is not considered cost effective anymore and should therefore not be reimbursed. And in some cases, multi-criteria decision analyses, in short MCDA, they are used to weigh broader societal and ethical factors beyond just the costs. One of the key metrics of cost effectiveness analysis is the incremental cost effectiveness ratio, in short ICER, and this slide will come back later, so it's important to go through it briefly. So the ICER, the incremental cost effectiveness ratio, represents the additional costs that are required to gain one extra unit of health benefit, such as, for example, life years. So what we do here, it seems like a very easy and straightforward formula. It is, but getting all these inputs for the costs and the effects of the new technology on the left side, or the old to be replaced, or the other technology on the right side, this is where most of the work is in. So in terms of costs, we not only consider initial costs, but also the downstream costs. And in terms of effects, we are not only interested in positive effects, but also in negative effects. For example, adverse events. What we then do is we subtract the costs from the old and the new from each other and divide this by the difference in effects. So delta costs divided by delta effects. For an example, if a new treatment costs, for example, 500,000 euros and provides 14 life years compared to an older 200,000 euro treatment, which offers 10 life years, the ICER can be calculated and would in this case be 75,000 per life year gained. And depending on what we are willing to pay or what a country is willing to pay, this ICER could be considered cost effective, and we would reimburse the new treatment and discontinue the old or the other technology. So far, I have focused on how classical HTA and cost effectiveness shape healthcare decisions. But what if we expanded our perspective beyond financial and clinical outcomes? The WHO Council on the Economics of Health for All advocated already in 2021 for a shift in how we define value for healthcare. It argued that economic evaluations should not just focus on efficiency and costs, but also on the impact on people and the planet. But unfortunately, health economists and others in the field have been quite slow in developing new frameworks for this and to integrate those. At the same time, there's also only little expertise, not much data to be used, and also the resources are rather limited for incorporating these aspects into economic evaluation or HTA. But instead of viewing environmental sustainability as an add-on, it must become a core criterion of healthcare decision-making. So as we move forward, integrating planetary health into HDA will require new frameworks, new metrics, and a broader understanding of value beyond just cost effectiveness. So if we would add environmental considerations to the aim of HDA, we would optimize, so to say, decision-making by integrating information on the environmental impact to the already assessed clinical and economic burden within the HDA or economic evaluation framework. But what are policy and regulatory backgrounds for this? The latest EU HDA regulation that entered into force in 2022 and will apply or is already applying as from the beginning of this year, 2025, could have been a very good starting point, at least within the EU. This new regulation includes horizon scanning of new and maybe also expensive health technologies. It also includes joint and scientific and clinical assessments between member states of these new technologies and aims to improve voluntary cooperation between all the member states within the EU. But it does not focus explicitly or includes planetary health aspects. So maybe this is a missed opportunity. On a more national level, organizations like NICE from the UK and ZIN from the Netherlands and others are already exploring how planetary health can be incorporated into HDA frameworks, and we will see a nice example after this presentation. But now practically, how are planetary health aspects integrated, or how can they be integrated in HDA or economic evaluation? Well, currently, this is mainly done by estimating the carbon emissions. And one key tool for assessing environmental impact is life cycle assessment, or LCA in short. LCA quantifies the environmental impact of healthcare products and services and is governed by ISO standards. LCA provides a standardized way to quantify emissions across the entire life cycle of a health intervention. So, for example, a medicine or a medical device, from the production up until its disposal. And this is in sharp contrast to economic evaluations that currently exclude life cycle effects of the considered technologies, because we are looking often only in economic evaluations at a snapshot. There are two main approaches to LCA, which I will discuss in the following slides. First, the environmentally extended input-output LCA approach, which estimates emissions based on financial transactions within different industry sectors. So this approach is built on many input-output tables, which are much like a bunch of Excel spreadsheets that include prices and CO2 equivalents across different national industries. This allows us to calculate carbon emissions per dollar spent in a specific sector. And here on the right side, I have an example for buying $100 worth of surgical and medical instruments. So with these EEIO, the environmentally extended input-output models, we could calculate what buying these $100 worth of surgical medical instruments would deliver as a CO2 equivalents, and depending on one of these databases, this would be 18 kilograms of CO2. But a key limitation to these EEIO models is that they provide only broad estimates across different industries and across different items, and do not capture product level variations. Also, they assume some kind of linear trend, and this is not always the case. So due to this limitation of the EEIO models, process-based life cycle assessments are regarded as a better alternative. And these models estimate emissions using a detailed process tree from raw materials to the product disposal. So all these different steps will be included. And this can be often much more precise than the environmentally extended input-output models for individual healthcare interventions. And process-based life cycle assessment, or PLCA, comes in generally two flavors. We have the attributional PLCA, which focuses on tracing emissions back to the activities that contributed to a product's production, consumption, and disposal. and they provide a snapshot of the environmental impact. So one example could be measuring the total emission from producing a specific medication, so a specific pill, for example, and distributing emissions among production steps from raw materials up until this is produced and later also disposed. On the other side, we have consequential PLCA, which examines how emissions change when a product or a healthcare activity is introduced or modified. And one example here could be the estimation of emissions saving when we are switching from intravenous to subcutaneous formulation of a drug. And I have an example for this in the later slides. But by using both models, so the attributional and the consequential, at the same time for different activities, we can better understand the overall environmental burden of these healthcare interventions or technologies and how they change with clinical practice and can potentially reduce emissions. But as I said, historically, estimating health impact and pollutant was difficult due to limited data and also limited framework. And you can imagine that conducting such analyses is quite time intensive and also resource intensive because all these different items need to be looked up for, measured, and valued. But recently, researchers developed a database, and this is a good start, of carbon footprint data for 12,316 oral medicines. And they provide a model, so a calculation model, with which the carbon footprint of new medicines could be based on the wholesale price alone. So if you have the wholesale price of medicine, this could be an input to this model, and this model would estimate the CO2 equivalence. I personally haven't used this model yet, but it's very interesting to see that in a relatively short amount of time, such a model is already existing and would make it easier to study and also to include these aspects into studies. Additionally, you can also rely on various LCA studies that have been analyzed and that are published in the literature. And they also looked at the carbon footprint of many interventions or healthcare activities, but also including patient transport, the mode of administration, so being here subcutaneous versus intravenous, the diagnostic imaging, surgery and pathology testing, but also radiotherapy. So this could be a very good starting point, but if nothing else is available, the environmentally extended input-output models may provide a very good, very first start of doing your own calculation. But if something is already out there and in the literature, that's a good reason to use it. So this slide can really serve as a reference for when you want to know more about specific aspects of healthcare activities, and the references are provided later on the last slide of this presentation. Recently, we conducted an own LCA study to compare intravenous to subcutaneous administration of cancer drugs, here in this case monoclonal antibodies. And we included aspects ranging from raw material to disposal of all items involved in this process. This is in this figure here. So on the left side, you see the raw materials, and on the right side, everything in blue was included, the waste disposal. Some aspects of the life cycle fell outside the scope of this study, as it is often the case, because here they were not directly related to the treatment or the administration of the treatment. So if you would need to use data from such LCAs, it is a good idea to maybe also look at the boundaries of the LCA and what was included and what not, because you might find yourself that some of these aspects might be relevant for your own study, but they were maybe not included. This table presents some of the model input parameters for the study, and these were used for assessing the environmental and resource-related impacts. So not only the environmental impact in terms of kilograms CO2 equivalents, but also the minutes so minutes that healthcare personnel took for administering this treatment, but also the distance. Many input variables could be sourced from previous studies, which is always good, of course, especially those on how much time it takes to administer these drugs. And the CO2-related inputs could mainly be sourced from the EcoInvent database, but also similar databases exist. So you don't only have to rely on the EcoInvent database, but for most, if not all databases, you need a paid subscription, which is unfortunate because this is not always directly available. So all things considered, the overall emission were similar for both drug administration routes, but with slightly higher emissions for the subcutaneous method when including drug production. On a local hospital level, SC, so subcutaneous administration emissions were 0.2 tons higher when compared to intravenous. And across the Netherlands, so if we scale this up to the entire Netherlands and all patients that would potentially receive this drug, the SC route produced 12.2 tons CO2 equivalents more than the IV route. But how can such examples now find their way into HTA? Well, this diagram illustrates how the carbon footprint of healthcare interventions could be incorporated into health technology assessment. At the top, we begin with a healthcare intervention, which could be a treatment, medical device, or any other procedure. Each healthcare item that is involved in this healthcare intervention would undergo one separate and distinct LCA to measure the environmental impact, similar to the examples that I showed earlier. And then these individual LCAs are put all together to estimate the total carbon impact. And once all these LCAs are completed, their results are compiled into a single value, mostly expressed in kilograms of CO2 equivalents. And this carbon footprint data can then be used in three ways. One, as a decision modifier, where environmental impact serves as a factor in the financial decisions, but is often not the primary criterion. It could also be used in multi-criteria decision analysis, where environmental impact is explicitly weighted alongside cost and clinical effectiveness, so one additional weighing factor for MCDA. And alternatively, when monetizing emissions, the carbon impact is converted into monetary terms and incorporated into cost effectiveness analyses, CEAs, or cost benefit analysis, CBAs. Currently, and this is based on a scoping review, there have been 4 main methods or frameworks crystallized out from the literature and suggested for integrating environmental impacts into HTA or economic evaluation. These models differ in their influence on decision-making and also how they incorporate sustainability. So we have, for example, information conduit, which involves reporting environmental impacts in recommendations or in the decisions, but does not actively influence the deliberation or pricing of the healthcare intervention. But essentially, the information is provided, but it is not considered in the final decision-making process. With an integrated evaluation on the right, all environmental aspects are directly incorporated into the cost or in the effect side of the evaluation. For example, the carbon footprint could be included as an additional cost, or environmental impacts could directly be translated and reflected into health-related quality of life measures. Another option is adjusting the willingness to pay threshold to reflect environmental considerations, as so far only considering effects, health effects, and costs. In a parallel evaluation, which involves conducting a separate but parallel evaluation of environmental impacts alongside economic evaluation. And here, 5 key approaches have been identified. First, one could be to calculate the incremental carbon footprint effectiveness ratio, so the ICFER, the incremental carbon footprint cost ratio. But we can also, as said before already, integrate this in multi-criteria decision analyses, incorporate into existing HTA deliberation processes, or alongside traditional economic evaluations. And last but not least, with an environmental focused evaluation, we would exclusively focus on environmental impacts without considering costs or clinical effects. So if you remember the ISER slide for the incremental cost effectiveness ratio, we had the difference in cost divided by the difference in effects. But if we look at the ICFER, then you can see that all outputs are expressed in CO2 equivalents. So so still costs, but not on the top of this calculation. The difference in cost that is in the numerator, usually for the ICER, is now containing the difference in carbon footprint. And the denominator here in this formula contains the difference in CO2 equivalents per monetary unit. So this is the incremental carbon footprint effectiveness ratio. Alternatively, in contrast, we have the ICFCR, which is the incremental carbon footprint cost ratio. And this one keeps the difference in health effects in the denominator, just like the ICER. So, for example, the difference in effects. But now in the numerator, this contains the difference in carbon footprint. So when we compare those three key metrics directly, we see that each of them has a distinct purpose and serves a distinct role when balancing costs, health impact, and environmental sustainability. The classic ICER is the most widely used, of course, until now, metric in HTA, but it assesses only the additional costs per unit of health gain. So lower ICER here means that the intervention is more cost effective usually and more favorable for adoption. But as we saw before, environmental aspects are usually not considered in the ICER. In contrast, the ICFER shifts the focus a little bit from the financial cost to environmental impact. It measures the additional carbon footprint per unit of health benefit. And here, a lower ICFER indicates more carbon efficient. So not cost effective, but carbon efficient intervention, which means that it provides health benefits with a lower environmental burden. This can, for example, be useful in comparing technologies that have similar health outcomes, but might maybe differ in their carbon or environmental impact. Then the ICFCR provides insights into how changes in spending for these health interventions would affect carbon emissions. This one calculates the difference in carbon footprint per unit of cost difference. And here, a positive ICFCR would suggest that increasing spending on an intervention would lead to higher carbon footprint, while a negative ICFCR would indicate that more spending results in carbon reduction, which might be a good thing. So this can help policymakers determine whether increasing healthcare investments align with environmental sustainability goals. But despite the importance of incorporating sustainability or planetary health into HTA, several challenges still remain. And these can be grouped into 5 key areas. One of them being lack of standardized methodologies. So there is no universal accepted framework as of yet for integrating environmental considerations into health technology assessment. And this, of course, leads to inconsistencies in how different organizations across the world or within the European Union, for example, would assess sustainability. Also, data availability and quality issues arise. Reliable environmental data for healthcare interventions is often lacking and also needs to be calculated from scratch. And the variability in data sources, including their quality, can lead to quite some uncertainty in environmental impact assessment, which policymakers have to deal with in the end. Also, complexity in measuring environmental impacts. Quantifying indirect environmental effects such as supply chain emissions is quite challenging and also quite resource and time intensive. Advanced tools and databases are really needed to provide more accurate assessments, and some of these are already starting, as we saw with these models that are able to generate CO2 equivalents based on wholesale prices, for example. But then also the integration with economic evaluation is also quite a challenge yet, because traditional cost effectiveness analyses focus only on financial and clinical outcomes, but they are so sustainability is rarely included, and also the knowledge of how to include this is still under development. So here, a framework could be needed to balance environmental benefits against economic costs. Last but not least, and this has come up quite some time already, limited awareness and expertise, because many HTA practitioners and researchers are unfamiliar with environmental assessment methods, and greater interdisciplinary collaboration, which is also really one of the core aims of HTA, being a multidisciplinary tool. And this interdisciplinary, multidisciplinary collaboration is really required to successfully integrate sustainability into health technology assessment. To wrap up, I want to go to the key takeaways from this session. So first, sustainability is not yet a formal criterion in HTA, but it is rapidly gaining attention. As environmental concerns grow, HTA bodies are beginning to explore ways to integrate sustainabilities into their healthcare decision-making, and some are a little bit further than others. Second, HTA agencies may soon incorporate carbon footprint and waste considerations alongside cost effectiveness and clinical outcomes. And this could reshape really how we assess healthcare interventions and prioritize technologies that minimize environmental harm. Finally, achieving this transition requires collaboration between regulators, HTA agencies, policymakers, researchers, and industry stakeholders. By working together, we can develop standardized methods for integrating these sustainability aspects and planetary health aspects into HTA and ensure that healthcare remains both effective and environmentally responsible. Thank you very much for your attention, and I hope that this presentation has provided some insights into the intersection of HTA and sustainability. I look forward to the questions that have been raised and to discussing them with you later. So thank you very much, and these are the references that you may want to check if you want to have a deeper dive.
Thank you very much, Frederick, for this overview. And we have already many questions, but we move on as usual with the case studies to leave all the questions at the end of the session. So now it's my pleasure to introduce Koonal Shah. Koonal is an associate director in NICE's Science Policy and Research team. His project portfolio includes contributing to NICE's efforts to reduce the environmental impact of the health and care system. Koonal has a PhD in health economics and decision science from the University of Sheffield, and he is an honorary senior research fellow at the Sheffield Centre for Health and Related Research. So Koonal, the stage is yours.
Thank you very much, Chiara. As mentioned, I'm based in the Science Policy and Research team at NICE, or the National Institute for Health and Care Excellence. Some of you will be familiar with NICE. We produce evidence-based guidance and recommendations for practitioners and commissioners to guide the use of health and care resources by the National Health Service in England. And our products include evaluations of specific health technologies and also clinical guidelines covering entire areas of care. So my case study that I'm presenting is going to go through how NICE has approached the challenge of helping to make the health and care system more environmentally sustainable. And to give some background, there was a recent Act of Parliament here in England, the Health and Care Act, which places a duty on NHS England and NHS providers to adhere to two other acts, the Climate Change Act and the Environmental Act. And it compels them to consider how they can support the UK to achieve net zero and other environmental targets. And what this legislation means is that the NHS's remit has expanded. It was previously just about supporting healthy people, and it's now about supporting both healthy people and a healthy planet. And specifically, the NHS's targets in relation to carbon emissions are to reach net zero by 2040 for carbon emissions it controls directly, and by 2045 for emissions that it influences. There are no specific implications of this legislation for an organisation like NICE, but they do provide rationale for our efforts to support the NHS to reduce its environmental impact through our guidance and other activities. Now, we've been taking some steps towards being able to measure and assess the environmental impacts of health and care interventions. We are some way off being ready to start incorporating environmental impacts into our assessments routinely, but we believe that one of the best things that we can do for the environment is to help ensure that any care delivered in the NHS is necessary and of high quality, and we are not using and using healthcare unwisely and unnecessarily. So at NICE, we have a program of deliberative public engagement, which we call NICE Listens. The purpose of NICE Listens is to give us a public perspective on challenging moral, ethical, or social value issues that we and our committees need to consider when we develop our guidance. Our main find and we ran a public dialogue on environmental sustainability in 2022. We sampled 23 members of the public, and they basically considered through various exercises and group discussions the questions that are shown on the slide, and they helped to guide some of the ways in which NICE has moved forward in this area. Our main finding was that participants supported NICE taking responsibility to make healthcare more environmentally sustainable. Many of them entered the dialogue somewhat skeptical about why this was NICE's business and indeed why it was the NHS's business. But we clearly observed that their support for sustainable healthcare grew as they learned about how it can support the outcomes that they were really interested in: improved population health, reduced burden on the health service, greater efficiency, convenience for patients. They were very interested in these co-benefits. So although much of the focus in this area is on trade-offs, based on this dialogue, we don't believe this is where the public wants us to focus our efforts. There was also public support for a number of other actions, including anything that NICE can do to help lower the demand for healthcare, for example, through our prevention guidelines. Any actions that we can take to reduce and restrict the supply of care that provides no benefits. So whenever we do not offer or guard against something, that is seen as very useful from an environmental point of view. NICE could also provide information on the environmental impacts of care options, for example, in shared decision-making processes. Anything that we can do, including via our HTA program, to influence the supply chain to prioritize and encourage green practices supported. And then also, where possible, making greener options the default, particularly for newly diagnosed patients. And then finally, there was some support for NICE considering the environmental impact of interventions under certain circumstances. So assessing environmental data and incorporating it into our health technology assessments is an area where there's been considerable interest. And this is something that we investigated in a article that we published a couple of years ago, where we focused on NICE's role as a health technology assessment body. So some of the points made in here were also shown in Frederick's presentations. I won't go through everything in detail, but basically we identified different approaches that HTA agencies can take to take environmental impact information into account in their decision making. So the information conduit role is somewhat distinct from the other options. So under this approach, environmental considerations would not affect our value judgments and decisions, but we would be using our influence to share information that has already been provided elsewhere. By contrast, the parallel evaluation, integrated evaluation, and environmental focused evaluation, they're potential approaches for combining environmental impact data with other types of impact data in our decisions about value. NICE is already doing some of the information conduit work in a limited capacity, and that will become apparent later in my slides. On the other hand, integrated evaluation involves fully embedding environmental impacts into HTA and creating new statistical methods or models that allow clinical, financial, environmental impact information to be synthesized in a single quantitative analysis. Parallel evaluation is a more flexible approach. It factors in environmental impact data into value judgments and those are considered alongside clinical and cost outcomes, and involves the agency presenting and analysing that data alongside established health economic analyses. So that might seem feasible while we don't yet have the methods needed for integrated evaluation, but it wouldn't get rid of the challenge of bringing environmental data into our decisions. It would just move the work from the data analysis step to the committee decision-making step. So I think it's clear that integrated and parallel evaluation would require HTA agencies to place a value on environmental impacts relative to health impacts, and we don't think that's an easy task. We're also the view at the moment we lack established methods and data standards that would allow us to understand robust and reliable analyses comparing the environmental impacts of health interventions routinely. And then finally, there's what we've referred to as environmental focused evaluation. So NICE currently only looks at technologies that are expected to offer some health or cost benefit compared to current standard of care, whereas this would mean potentially looking at technologies that are used in clinical settings but are not expected to improve health-related outcomes, but rather they claim to have relative environmental benefits. So nitrous oxide capture and destruction technologies are an example. So this is not an area where NICE has worked historically, but it is something that HTA could play a role in the future. So here's an example of NICE taking an information conduit approach. So as well as our guidance products, which involve our independent committees making value judgments and making recommendations about what is and is not used on the NHS, we also have advice and information products. And one of these is our asthma inhaler decision aid. You may be aware that some types of inhalers have a bigger carbon footprint than others, and specifically pressurized metered dose inhalers, because of the compressed propellant used to deliver the medicine, they have a much higher global warming potential than dry powder inhalers. And this is one area where environmental impacts are quite well established and where high quality comparative studies have been published. So we recently updated our decision aid to provide information on the environmental impacts of different inhaler options. And that's mainly to facilitate conversations between patients and healthcare professionals and allow them between them to make a more environmentally friendly choice. We've been really careful not to frame anything in the decision aid as coercive or as something that patients should feel guilty about. We make it clear that patients should speak to their healthcare professional about their decision and before making any changes, weighing up the various advantages and disadvantages that matter to them personally. So as you can see from this screenshot, we provide simple, easy to understand information on the carbon impact of different inhaler types. We briefly explain why that matters, and we show how the doses of these inhalers compare to other activities and with well estimated environmental impacts, specifically petrol car journeys. So as well as inhalers, another well-known environmental hotspot is anesthetic gases. There are 4 main inhaled gases used in anesthesia, and there is significant variation in the environmental impact of different gases. So desflurane is known to be a problem gas. Its global warming potential has been estimated to be about 40 times that of alternatives such as sevoflurane. The NHS in England announced the decommissioning of desflurane by 2024 on the grounds of its global warming impact. But they identify that there may need to be exceptions for circumstances when it's acceptable to use it. Well before they announced the decommissioning, there had been progress made in reducing the use of desflurane without any input from NICE, but there was still national variation, and the NHS felt that NICE had something valuable to offer in terms of our evidence review capabilities and objective approach. So in response to that, NICE has produced an evidence summary that reviews the clinical outcomes and resource impact outcomes of desflurane versus alternative anesthetic agents. So we didn't look at environmental impacts. The purpose was to understand whether there is any evidence that points towards the need continued need to use desflurane in certain circumstances. We felt we didn't have the skills to do a review of environmental outcomes, but we do have the expertise to review evidence on clinical and resource impact outcomes. And unlike our HTA program, we didn't make any value judgments. We didn't make any recommendations in this work. We did it to inform policy making by our system partners in NHS England. So that work has helped to ensure that patient outcomes and safety are not being compromised by efforts to improve environmental sustainability. So that's in keeping with our remit, and it's also in line with what the participants in Nice Listens told us. Don't focus on trade-offs, focus on the areas that are win-wins, or at least you are not making anyone worse off by doing something that is more environmentally sustainable. So the NICE evidence summary was published in March 2024, about a year ago, and the linked NHS guidance on decommissioning desflurane was published on the same day. So personally, I feel it's really great to have a tangible output like this from our environmental work programme. Thank you very much. That concludes my case study.
Thank you, Koonal. Thank you very much. We leave the questions at the end, as already said. So we move on with Rhiannon for the last presentation. Rhiannon Reising is a junior researcher at Maastricht University Medical Center in the Netherlands. She's pursuing a PhD, and she's a trained nurse in Germany with more than 1 year and a half experience working on the ICU at the University Hospital Erlangen in Nuremberg. She pursued the Master in Healthcare Policy, Innovation and Management at Maastricht University, during which she conducted the research in collaboration with the Dutch Healthcare Institute on integrating environmental impacts into HTA. And since September 2024, she started a position at Maastricht University Medical Center as a junior researcher working on the Carefree multidisciplinary research project, focusing on health economics and HTA and how to integrate environmental sustainability into HTA. And so here she is with her presentation.
Thank you very much, Chiara. First of all, thank you so much for the invitation today to present my research. Yeah, so my name is Rhiannon Reising. I work at Maastricht University Medical Center at the department Kempter. At Kempter focuses on clinical epidemiology and medical technology assessment. And in September, I started my PhD on integrating sustainability within HTA. But before that, I had a placement at the Zorg Institute, actually, and my supervisor there had suggested that I do research on integrating environmental sustainability within HTA because they are looking into it more and more, like already mentioned by Frederick and Koonal. Also, the NICE is focusing on it, but also in the Netherlands, there's an increased attention on focusing on incorporating environmental sustainability into HTA. So, I conducted some research which I would like to share with you all today. But first, just to give a short background. So in the Netherlands, we have the HTA body, as already mentioned, is the Zorg Institute, and the Zorg Institute ensures accessible and high quality healthcare for all Dutch citizens and advises the Ministry of Health on which health technologies are included in the basic benefit package, so that are covered and reimbursed by the healthcare insurance. And when doing this assessment, they consider several factors. So they consider clinical effectiveness, cost effectiveness, the necessity of the treatment, and also the feasibility. And within these factors, like Frederick already mentioned, they look into also productivity losses, the patient and family costs, and more there is an increased attention to also incorporate sustainability, environmental sustainability within this assessment. Currently, the Zorg Institute are working in various ways on incorporating sustainability in their work. So one of the ways is that they have a temporary committee currently that is focusing on labor development and environmental sustainability, and how this should influence the selection of various healthcare services to include in the basic health insurance package. Another way they're looking into sustainability is by incorporating it into quality standards and guidelines. So, for example, they have guidelines where they've integrated sustainability into professional healthcare standards, but also have used environmental impact as a criterion in the quality assessment framework for healthcare guidelines. And they also conduct research and develop knowledge on incorporating sustainability within their work, and also work in collaborations and networks, for example, working with various green teams, for example, throughout multiple hospitals in the Netherlands, to basically have also discussion with various stakeholders. One example of research and knowledge development is this article that was published also with the Zorg Institute, which also looks at inhalers, as Koonal already mentioned, and they found that the inhaler that is the most eco-friendly also saves costs. So this is something that definitely is a good example of how we don't have to make always that trade-off that necessarily a health technology that is more environmentally friendly would necessarily cost more, but it could also even save costs. So Frederick and Koonal also already mentioned the methodologies, and I'm not going to go into detail in this presentation now, but this was the baseline of the base of my research. So there are various methodologies and a lot of knowledge of how we can incorporate environmental sustainability into HTA, but there's no clear consensus which is the right way to go. And that was basically the discussion that I had with my supervisor last year from the Zorg Institute, that we know we can do it like this and this and this, but nobody really knows what's the right way to go. So from that, we decided that we would, or I would conduct research on looking at Dutch stakeholders' perspectives on integrating environmental impacts into HTA. So the research question were, what are the perspectives of the various stakeholders in the Netherlands on the methodologies of integrating environmental impacts into HTA? And we wanted to really have an approach where we had various stakeholders, so not just members of the Zorg Institute, but also incorporating academic experts and also experts of industries, for example, pharmaceutical industry, because if the Zorg Institute, for example, makes it a mandatory requirements to incorporate environmental sustainability within HTA, then this also impacts industry, because then they have to conduct life cycle assessments, which is also more work for them. So we really wanted to have an approach where we had various stakeholders to have a good view of what was going on. I conducted qualitative research, which consisted of one focus group interview, which were with members of the Zorg Institute, 7 members of the Zorg Institute, and then 7 individual expert interviews, like I already mentioned, academic experts. Then I had 2 experts from market access and reimbursement in the pharmaceutical industry within the Netherlands, and also in the medical technology industry, and also health technology assessment consultants. And the questions, they were based on the methodologies in the table that I just showed, and the one that in the other presentations was where they already explained. And the questions were aimed to identify the challenges, barriers, and strengths, and overall the opinion of the various methodologies. And additionally, I also asked the participants which methodology they preferred. And the main results from this research were that all stakeholders were really of the opinion that it's a very, very important topic, that we should really have more discussion surrounding this topic on how to incorporate, which is the right way to go. Also, a lot of discussion around which environmental impact also should be considered. Should it only be carbon footprint? Should we also look at pharmaceutical residues or plastic waste, or all these different environmental impacts? So that was very, very interesting. And there was a lot of variation also in knowledge and implementation. So a lot of stakeholders knew that it's important, and that also knew the various methodologies, but they didn't have any experience in implementing the environmental sustainability within their work. There were some people who did, like some people had used grey literature, for example, to calculate the standard intervention with a new intervention, and then it was to do with waste, and then they, for example, had grey literature that, okay, with this new intervention, this would save this many bags of waste. but it's very like not really standardized and very difficult to calculate. And overall, there was a preference for integrated and parallel evaluation. So the methodology that was most preferred by stakeholders was cost utility analysis, either through converting the environmental impact into a monetary value or by converting it into a utility. So, for example, quality adjusted life years or disability adjusted life years. And the second most, the second methodology that was preferred the most was an MCDA, so multi-criteria decision analysis, where you have environmental impact as one criterion, and you would weigh that with other criterions. And the clear challenge that we saw throughout this research was the lack of data availability. So there are not enough life cycle assessments, which, if we don't have the life cycle assessments or we don't have the data of the actual environmental impact of a health technology, then we cannot even incorporate it. So that's something that really has to be done first before even thinking about incorporating it into HTA. And also, especially the stakeholders that were not at the Zorg Institute, they felt that there was a need for clear guidelines and methodologies within their work. How can we incorporate into HTA? Or also in industry, they really needed more guidance on, okay, which environmental impacts should we collect data on? Is it only carbon footprint, or should we also look at plastic waste and these kind of things? So those are the main results of my research, and currently I submitted it, but it's still it's not published yet, but yeah. So within my work, from September when I started my PhD position, I'm working within a project called Carefree, which stands for Creating a Healthy Environment for Future Patients, and it's a judge-wide project. We focus on laparoscopic cholecystectomy, so removing the gallbladder through minimal invasive surgery. And the project is a trans and multidisciplinary approach where we gain insight into stakeholders' motives on making the operating room more green, based on the 10 R's of circular economy. And we have researchers from lots of different areas, so from social psychology, sustainability research, pharmacology, toxicology, and also health economics. And I am the researcher that is focusing on health economics and how to incorporate a health economic perspective within this project. So yeah, this is just a map of where we're based. So we're within the whole of the Netherlands. And this is the framework of Carefree. So like I already mentioned, we're focusing on laparoscopic cholecystectomy, and we have 5 work packages. So the first is refusing surgery, for example, that we can prevent even a patient from having the surgery in the first place, which would limit the environmental impact. Then the second work package is focusing on replacing anesthetics. So that's comparing intravenous with inhalational anesthetics. And there you can see in the yellow box, economic analysis. So these are the work packages that I am working on. So at the moment, I'm looking into comparing the costs of inhalational and intravenous anesthetics for decision makers to also have that side of the project to look at it from a health economics perspective. And then the third work package is reused trocars. So the trocars are the instrument that are used to insert into the patient for the minimal invasive surgery. And we have reusable trocars, but we also have disposable. And there also we were looking at like the economic impact of using reusable as opposed to using disposable, which is the standard of care currently. And then the fourth work package, which is the one I'm also working on, is reducing HVAC. So HVAC is the air treatment in the operating theatre to also prevent infection. And this is on the whole time, and it's basically a discussion whether that's necessary. So there we also are looking at the economic impact. And then finally, the fifth work package, which I'm not working on, is recovering residues. So for example, with the intravenous anesthesia, there is also an environmental impact, although it is more environmentally friendly than inhalational anesthesia. But there we also have people looking into the impact of that. So that's just an example of a project currently in the Netherlands where we're looking at this topic. And I'd also like to just share this slide of some of the work that my colleagues in the Carefree project have published. And that's the end of my presentation. Thank you.
Thank you, Rhiannon. So we have around 20 minutes left for the Q&A session. So Frederick, Koonal, and Rhiannon, we start with the questions. The first question is actually directed to both Frederick and Koonal for their different viewpoints on the cancer therapy for Frederick and on inhalers for Koonal. So participant ask, I know that HTA is targeted at policymakers, but do you see this type of information also factoring into information provided to patients? And in the examples given by Frederick on cancer therapy, if a patient knew one has less environmental impact than another, that might influence the route they ask for.
Because this is a specific example in my presentation, I would like to respond to this. I think that this is one of the crucial challenges in also incorporating this into HTA or economic evaluation. Because at the end, when we do HTA assessments and economic evaluation, we make decisions for a population, for a country, basically, whether a drug is reimbursed or not. So this would include, and hopefully also include, a patient perspective, because in the end, if there is an option still to give IV or SC, then of course the patient needs to decide in co-decisions with the doctor, of course. But often this is not the case because one of these interventions would not be financed and also not be reimbursed anymore. So these decisions are made somehow on a higher level. And one of the key problems or challenges I see at the moment is that we simply do not have enough stated preferences of societal preferences, for example, of how to deal with these cases when we would have to forgo health in exchange for gaining planetary health. So personal patient health would be forgone, but then we would save some CO2 emissions. At the moment, I'm not aware of any preference studies, so I don't know how different, and this can be different for all the different, for all countries, for example. When we look at the willingness to pay thresholds, they're also different in all different countries. So I think that there's still a lot of work to be done and also eliciting patient preferences, but also stakeholder preferences in general to see how far we can go and how far we need to go. But on the other side, I mean, giving something as an additional information to patients, if they have the choice, that could be also a first start.
Thank you, Frederick. Koonal, do you want to add anything about inhalers?
Yeah, sure. So HTA is often, as the person asking the question suggests, directed at policymakers or payers. And in the England context, in our technology evaluations of medicines, there is a funding mandate. So our recommendations, the NHS is then required to provide that on the NHS. Where you can have a more of a patient or healthcare professional targeted route would be where it links into clinical guidelines. So as well as doing technology assessments, NICE also produces guidelines, and the main audience for these guidelines are health and care professionals. So where you can incorporate the findings of a technology evaluation or any other evidence into a guideline. This is also a means of reaching a broader audience and informing choices which aren't necessarily linked to a mandate about what's provided. And just to pick up on Frederick's point about preferences, I'm aware of one study that has at least piloted looking at the trade-offs between human health outcomes and planetary health outcomes. It was led by researchers at the York Health Economics Consortium. I can't remember what journal it was presented in, but Melissa Pegg was the lead author. So it was, I think we need a lot more of these studies, and this would be sort of very helpful in guiding future exchange rates between different types of outcomes and identifying, potential decision-making thresholds. But yeah, it's scarce literature at the moment.
Okay, thank you very much. I may add a question also going into this direction, mainly directed to you, Frederick, but I think Koonal, if you have any interesting additions to that, please feel free to add. This question is coming from Johannes, and he's asking, do you have any example where a carbon footprint was used in an MCDA, and what was the relative weighing of versus the other factors? And he also adds to the same question, also from Johannes, are there any attempts to include other key environmental impacts that might be locally relevant, like the use of water or others?
Yeah, thank you very much for this question. This is for me difficult to answer because also for me this is quite a new field. And recently in December, a PhD started on our institute to really look into this and have different methodologies applied to just one case study, so that we see the differences. I'm aware of one MCDA, but I cannot quote it because it's still under study, and hopefully it will be submitted soon. But I was not involved in this, so maybe Koonal has more information, or any other panelists have more information on this. But yeah, I think this is an emerging field, and lots of these studies still have to be done. I was not directly involved in an MCDA in this, so I won't know.
Okay, thank you. Maybe Koonal, anything to add,
Yeah.
or Rhiannon as well?
Well, in an England context, no. NICE doesn't use multi-criteria decision analysis. We use a sort of more deliberative approach to taking different factors into account. I can certainly envisage that this would be a useful route for research. So trying to test a multi-criteria decision analysis in a research setting would be really helpful here. I believe that in Canada, our counterparts, formerly known as CADETH, now the CDA, have done this in a limited degree for non-drug technology evaluations. I believe the example that was used was water fluoridization, where they considered environmental impacts alongside the more traditional outcome measures. I'm not sure if they would describe it as an MCDA, but they've got a few examples of that in action.
Okay, thank you very much. Maybe adding a personal question to this regard. In the end, I see there is a dilemma in the moment where you introduce a new measure, like for example carbon footprint, but it can be any kind of indicator for environmental impact. If you introduce it into the equation, you're trying to compare apples with oranges. And wouldn't it be logical, or just to convert the carbon impact or any environmental impact that activity in the healthcare sector has, convert it back into a financial number and then reintroduce it into the health technology assessment in order to have a equal field, put a price on the carbon units, and then introduce them and treat them in a conventional manner? Wouldn't this save a lot of work?
It's an interesting suggestion. In any case, I think when you are adapting methodologies for new technologies and you have not used the same methodology for older ones, then you are always comparing apple with oranges in a way, because these comparisons will not be fair. If you compare two existing or like a new treatment that's coming to the market with an alternative, so a comparator with the same methodology, then I think at least this comparison is fair, but it might not be for the previous ones. And we also have to realize that we can sometimes, also compare a new treatment to something that was not cost effectiveness already, although it was implemented. So at some point we need to start, of course, and we currently have non-cost effective treatments in the healthcare basket. So these treatments, they still need to be evaluated. So we would have to go back, and I'm not sure if just incorporating this on the cost side would be the ultimate solution, because ultimately the planetary health aspects are not only to be measured with the cost aspect, but also have health impacts, and these also still need to be counted.
I think there is some merit to that suggestion. I think it's an open question about whether environmental impacts should be incorporated on the cost side or on the effect side. And there are such things as like a social cost of carbon that are used in policy making. So there are numbers that can be applied here, and it sort of fits with the theory of it being like an externality. The other way of approaching it would be to have high quality research on societal preferences and the willingness to trade between human health outcomes and planetary health outcomes, and to define it that way so that everything is in the same unit, but as a health outcome. The other thing worth noting is that from a health system perspective, the main reason we're interested in environmental sustainability is because of the ultimate impact it has on human health outcomes and also on healthcare resource uses. So another way of doing it is you have research that shows the impact that environmental impacts then have on human health outcomes, and you apply that on top of the human health outcomes that you're already taking into account. But I mean, I think that's very complicated, but I think there's different ways in which you could approach the issue of where it lands. Just one quick thing. I think in the previous question there was asked about like other environmental domains beyond carbon. So NICE's focus has been on carbon and greenhouse gas emissions, and that's largely reflecting the NHS's focus. But I don't think that's any statement that that this is the most important or the only important environmental domain. I think it's probably just the easiest to measure, and the one where there has been like the specific policy targets. But yeah, there are all sorts of environmental domains like water use, pollution, ecotoxicity. They are all important, but I think we're even further off being able to measure them and value them consistently.
Okay, thank you very much, Koonal, for these remarks. Playing the ball back to you, Chiara. Any other questions from the public?
Yes. Now I would like to pose a question to Rhiannon, because a participant asks on the issue of reusable medical consumables like trocars. Is there a standard for disinfection or sterilization of the consumable for reuse purposes? And in terms of anesthetics, how were you able to convince policymakers and clinicians who were reluctant to change?
Yeah, so with the reusables, I'm actually in the process of, I had a meeting also this morning. We're looking at the sterilization process of the reusable trocars, because we're also not sure whether it's done the same in every single hospital, or yeah, sometimes you also have external organizations that sterilize and then they bring it back to the hospital. So that's something that we're looking into, but we also have somebody who's specifically conducting the life cycle assessment, so that's not my job. So she has a little bit more insight into that. And with the anesthetics, yeah, we also had a few meetings with the project leader of that work package on anesthetics, who's a clinician, and he also said that it's funny how, yeah, we know that inhalational anesthesia is like really, really bad. And actually in the guidelines in the Netherlands, it's the standard is to use intravenous anesthesia and only use inhalational when it's really necessary. But clinicians are really, really reluctant to use intravenous anesthesia. And we will also have some other research, but that's also not my research, that is ongoing currently, looking into, why is there this reluctancy to actually use intravenous anesthesia when we clearly know that that's the best way to go environmentally. So we hope that through maybe the research that I'm conducting, looking at the costs, that maybe clinicians have more of an incentive to also then use intravenous anesthesia as one of the criterions. If they know it's going to save costs, then to ultimately transition. But we have to look into it further. Yeah.
Thank you, Rhiannon, for marking this out. I will maybe add a question to your direction. There's one person who is asking you to talk more about the carefree interdisciplinary team. What are the benefits and the challenges that you have found working across such a diverse disciplinary backgrounds?
Yeah, so the project actually started before I came in, so I've missed the beginning of the project, but I think at the moment it's actually just interesting to look at it from various perspectives, and we have meetings every 3 months where we come together and share our research, and so we have, like I already mentioned, people from ethics, looking at the impacts, like morally, and also psychology and implementation science. And I think we can really learn from each other. Like, for example, for us as health economists, it's like we see, okay, well, intravenous is better for the environment and than inhalational, and actually in some studies it also shows that it's actually more cost effective. So we're like, why are we not using intravenous? And then you have conversations with others, for example, clinicians, and then learn, because a lot of the time, unfortunately, also in hospital, I know this myself as a nurse, that people are really reluctant to change because they're like, this is the way we've always done it, so let's just continue doing it like this. So that's really interesting to see, because if you would see from our perspective, you would think, well, it's kind of like a no-brainer, you just go and do intravenous, but it's not like that. So I find that really, really interesting. Yeah.
Okay, thank you. I figure this is probably a setting where a lot of people find themselves in entering in this type of work. We are slowly coming to an end, but there's probably room for 1 or 2 more questions. So I'm going to ask, this was directed to you, Rhiannon, as well, but maybe the others can jump in as well. Does the European regulation, I presume this is European Union, require or take into account environmental assessments and carbon footprint data for the registration of medical devices or medicines?
Maybe I can respond to this, because so there is an environmental risk assessment that the European Medicine Agency is requiring by EU law, and this is already up and running since 15 years, and this is for all new medicines in the EU. Such environmental risk assessments, they primarily evaluate the persistence and bioaccumulation and toxicity of these new medicines, but so far, this is, I think, not really included, for example, and there was another question from in the EU HTA regulation. So the EU HTA regulation is really only looking at these pillars that I talked about, for example, the horizon scanning, the joint scientific, and the joint clinical assessment, but it does not incorporate these data. And I'm not really sure what to make of this and how this really could help, because I haven't looked into an environmental risk assessment specifically yet. But I think that some of the elements that we try to include, maybe not directly the carbon footprint, but many of these assessments could be already available in these environmental risk assessments. So some of the data is already gathered by manufacturers before going to the EMA for marketing approval.
Okay, thank you for clarifying. Chiara, is there any last question that you would like to pose?
Yes, probably just really a quick and final comment because it's a European course, we know, but we have many participants coming from the global south. So we see that it's a challenging issue in the global north, but how do you see it from a low and middle income countries perspective? Any recommendation, any suggestion that you might have for our participants?
Maybe if I could say something on that. Even in the absence of being able to measure these environmental impacts well and to be able to put valuation on it, the one thing that we can be pretty confident of is that using less healthcare is going to be more environmentally sustainable. And that kind of applies everywhere. So anything that is focused on prevention or on reducing the use of low value care, or unnecessary care, harmful care, we kind of know that is going to be good for both for all three, for costs, for human health, and for planetary health. So I think that is a good area to start, regardless of where we are in the world.
Okay, yeah, thank you very much. I think that's a beautiful closing statement. Everything that is good for human is probably very good for the planet as well. I think I would like to appreciate this last minute to thank you all for participating today and for speaking, obviously, and the three panelists. And all the more than 1,300 participants that we had today. Please take a minute to do a post-session survey. And we will see you at the next session, session 8, next week, Tuesday, same place, same time. Yeah, thank you very much from my side. Chiara, any closing remarks from your side?
Thank you very much to the speakers, to you, Eric, to be my share moderator in this session. And thank you to all the participants, of course, to attend this session and the following ones. Thank you. Bye.
Goodbye.